thank you for the opportunity to speak with you today. It's always lovely to meet with people face to face, and thank you, Kathy, for sharing your story. I'm also aware that there are many stories in this room, so it's lovely to have you here, and I look forward to a little bit more interaction with you during the Q&A. Today I'm talking about the emotional impact of ovarian cancer, and I'm going to focus specifically on fear of cancer recurrence. But before we do that, I'll touch briefly on some of the aspects of cancer generally, as well as some of the things that are perhaps more common or can be emphasised within ovarian cancer that are sources of distress. Although I think the last talk is a good reminder of the fact that cancer occurs within the rest of life. So there are lots of things that contribute to our emotional well-being, to our resilience, and perhaps the distress that we may be experiencing at one time or another. So a few of the ones that I've got up here on the slide are things that can change initially with any major life event, but a cancer diagnosis is a large one. That tends to change the way we view things, and it can have a really significant impact on relationships. That can be two-way. It could be that we have friends and family members who are in shock themselves, who perhaps feel awkward about talking about cancer or who feel like they don't know what to say. It could also come from the other side where somebody who's being diagnosed with cancer or is going through cancer treatment feels like suddenly other people just don't get it anymore. They don't actually understand what someone's going through, and that there may be a bit of a disconnect there. So that can feel a sense of isolation. And really, I think it's important to try and find people that you can talk to, people who genuinely listen and understand, and perhaps to connect with other people that have some similar experiences. So that may be through a support group. It may be just more informal than that, and talking with people who have experience of cancer and going through cancer treatment, who find it easier to understand what you're experiencing. Handy being the third speaker in the night, we've already heard about some of the physical aspects of ovarian cancer and its treatment, and those can have a significant impact on body image, things like hair loss or weight gain, post-surgery changes to sexual function or changes in fertility. All of those things can contribute to shifts in body image, self-esteem, confidence, and also, of course, intimate relationships can be directly affected by that. There can be big changes in identity, so sometimes the roles change significantly. If you go from working to not working, you may go from being a carer for others to being somebody who is now being cared for. All of those things have a significant psychological and emotional impact. So for some people, at the bottom there I've got anxiety and depression. For some people, these things amongst many others in life can culminate in clinical anxiety and depression. But for most people, they will contribute to distress of one kind or another. So rather than dwell too much on these, I want to move to thinking about coping strategies and to think about what you can do about these things. And to do that, I'm going to use a framework that was put forward fairly recently by a colleague of mine, Helen Stallman. Helen was at UniSA until recently. She's moved to Queensland, which is a great opportunity for her, but a loss to us locally. But Helen put forward this model as part of her Care, Collaborate, Connect program. And you can see that we've got distress going from low distress right through to high distress. So no matter what we're going through in life, we'll all experience distress at one time or another. And it can range from low levels right through to quite high levels. Whenever we experience distress, we tend to engage in coping strategies, and they can be healthy coping strategies. They can also be unhealthy coping strategies. And we all engage in both of these, so it's not one of those, how dare you do those things. Often our unhealthy coping strategies are things that have worked for us in the short term or in the past, but are not particularly helpful in the long term. So some examples of those might be things like increasing alcohol consumption, lack of sleep over a long period of time, that negative self-talk or worry, which I'll talk about a little bit more when I talk about fear of cancer recurrence, as well as social withdrawal. Sometimes that can be a protective thing and helpful in the short term, but long-term disconnecting from others can actually contribute to those feelings of isolation, to depression, anxiety, and so on. So on the flip side, there are a whole range of healthy coping strategies, and these are all things that I'm sure you've used at one time or another as well. And it's lovely that some of these have already been raised tonight. Things like exercise, eating well, making sure that we get sleep or rest if we're not able to sleep, learning some relaxation strategies and connecting with others. There's a whole range of things there that apply to all of us, whether we are undergoing treatment for cancer, whether we're caring for someone with cancer, or in other aspects of our life if we're experiencing distress. So, I think it's really important to ask ourselves, what are my healthy coping strategies? What are the things that I can do more of? And I think particularly for tonight and what we're thinking about, it can be really helpful to think about what are the specific strategies that are helpful in this setting. So it might be a support group, it might be touching base with a GP or referral to a health professional, particularly as you get to that higher end of the continuum. What are my unhealthy coping strategies? Being open and realistic about those. When am I likely to experience distress? We can actually be a little bit proactive here. If we know that I'm likely to be more stressed or feeling less sure about things around the time of medical appointments or scans, we can actually put some coping strategies in place to help us navigate those times. And finally, who is part of my coping plan? So when we're thinking about our coping plan or coping strategies, often we just think about ourselves. Reaching out to other people, who is part of that coping plan? It's likely to be a range of health professionals, from a GP, medical oncologist, cancer care team, perhaps the Cancer Council helpline, online support groups. There may be a whole range of those more professional supports, but there's also the people in your life who are supportive and who lend a listening ear and who are helpful to you, and they can actually be part of that coping strategy. Okay, so I wanted to make sure I left time to focus on fear of cancer recurrence. This is a topic that has been gaining a lot of attention in recent years, and with good reason, because it's particularly prevalent and the impact can be quite significant. So fear of cancer recurrence is fear, worry or concern relating to the possibility that cancer will come back or that it may progress. This has been identified as a particularly common issue, and also as an unmet need for women with ovarian cancer, but also people with cancer more broadly. So the characteristics of fear of cancer recurrence are high levels of preoccupation and worry about cancer that persist over time. So it's really normal to have worries about cancer. We're not going to pathologise that, it's quite a normal response. But if that worry is persisting over time, if it's interfering with daily functioning, which is the final point on that slide, then it may be something that requires some additional support or attention. It tends to lead people to become really aware of physical symptoms. So we tend to do this thing where we actually scan our body for physical symptoms, where we become really aware or hypervigilant, very aware of what's going on in the body and symptoms. And as we heard earlier, it might be feeling really tired. Is that the cancer coming back? That we tend to leap to that immediately. It may lead to a lot of reassurance seeking, wanting a lot of tests, scans, or health professionals' opinions. But the flip side is it could also lead to avoidance of those tests and getting things checked out, which obviously can also have negative outcomes. So really important to acknowledge that fear in itself is not a bad thing, and fear of cancer recurrence is not a bad thing. It's a really normal thing, but it's something that if we have too little fear, then we're probably not motivated to make changes in our lives and to respond appropriately to symptoms and so on. But if we have too much of it, it can really contribute to psychological distress, to anxiety, depression, and to lower quality of life. Importantly, I think the content of those fears can vary significantly from one person to another. So there are a few examples up there. It may be that the fears relate to treatment itself. I just don't want to go through treatment again. I've done that. I can't face it again. It might be about concerns about the impact that a recurrence might have on other people in your life. It could be to do with the financial burden, or it could simply be fear of death. as I said, this is a really prevalent problem, and it ranges from low levels of fear of cancer recurrence through to quite high levels. There was a large review of over 130 studies, I think, that found that 50% of cancer survivors have moderate to high levels of cancer recurrence. So this is quite common. Of those, 10% have high FCR or fear of cancer recurrence. So 1 in 10 is going to have a high level, which is really having a significant impact on life. A few final comments about the nature of fear of cancer recurrence. It tends to persist over time for high fear of cancer recurrence. So you might think intuitively, well, the further I get out from finishing treatment, the less concerned I'll be about this. But the high fear of cancer recurrence does tend to persist for some people. It's not necessarily proportional to prognosis. So there are some studies that have looked at groups with poorer prognosis, head and neck cancers, for example, and they found that they actually don't have higher fear of cancer recurrence than other groups with better prognosis or higher likelihood of cure or of being relapse-free. As I've mentioned, it's associated with high distress, with anxiety, depression, and with poorer quality of life. So it's really important that we actually address this. It can have a significant impact on all of life. Thinking about ovarian cancer specifically, one review reported that women with ovarian cancer, that the prevalence ranges from 22% to 80%. That's a huge range, and that's largely due to differences in the way that fear of cancer recurrence is measured. But importantly, 1 in 10 people in one of those studies said that fear of recurrence or death was their greatest challenge during treatment. There was another study that looked at the frequency of thoughts of recurrence, and you'll see in that diagram that 25% of women reported having thoughts about recurrence weekly, and 12% reported thinking about that daily. And these were women who were 7 years relapse-free. So there's been a long period of time since completing treatment, and yet these thoughts of fear of recurrence are quite frequent. I guess the good news about this is that there is treatment for fear of cancer recurrence, and there are ways of managing this so that it doesn't have such a significant impact. Really importantly, we're not trying to get rid of fear of cancer recurrence. We're not saying you should never experience fear or worry. That's perfectly normal. But what we want to do is learn strategies for managing those fears so that they're not pushing us around so much, that they're not having such a significant impact, and that it's not such a pervasive fear. So things that are important. One is being aware of triggers. So we know that fear of cancer recurrence is likely to increase around particular times and events. Having scans, regular checkups, anniversaries are a significant one, noticing particular anniversaries, or hearing about somebody else's story, hearing someone in the media talk about their diagnosis or their experience, maybe having a friend or another person in your network share their story may also lead to increases of fear of cancer recurrence. It can be important, I think, to seek advice from health professionals who have a lot of experience, and it's been really lovely that we've already heard some of that tonight about when should I really be worried, how quickly should I get something checked out, and if I do get it checked out, how long will it be until I find out the results of particular tests and so on, so that you're informed and you have a sense of control over what's happening for you. Going back full circle to the beginning of this talk, at those times you can engage in your own coping strategies and engage in self-care to help you better navigate those. But of course, when that's not sufficient, you can seek other support, and we now have some really good evidence-based treatments for fear of cancer recurrence. So the two main ones that I'm going to talk about, one is cognitive behaviour therapy. You've probably heard of this because it's arguably the most pervasive approach to treatment of psychological disorders. Cognitive behaviour therapy, or CBT, looks at the relationships between thoughts, feelings and behaviours, and may help you come up with alternative ways of thinking about recurrence or cancer. We also tend to have a series of beliefs about worry, and so CBT can help us look at those. Sometimes we have positive views about worry. So an example might be, worry will mean that I'm prepared, or worry allows me to problem solve. If I worry, then I'll catch something really early. But we can also have negative beliefs about worry. Things like, if I worry, that will cause a recurrence. Worry will cause cancer. So actually addressing those can be particularly important and helpful. The second approach there is actually a group of approaches or therapies, acceptance and mindfulness-based therapies. These approaches have been gaining a lot of attention over the last decade or so. I keep saying that these have become recognised recently, but I realise I've been saying that for at least 10 years. So how many people in the room have come across mindfulness before? Yeah, nearly everyone, so I don't need to dwell on this, but we're missing a bit of the slide, but that's okay. Mindfulness is the ability to pay attention to the present moment without judgment. And so it allows us to get outside of our heads. We're often worrying about either the past or the future and not really connected with what's going on in the here and now. And mindfulness allows us to do that. I've just got a couple of examples there on the slide of some of the evidence we have supporting these approaches. There's a program called Conquer Fear, which was actually developed by some collaborators in Sydney and around Australia that has some wonderful outcomes that have been shown in a randomised controlled trial, which is one of our highest levels of scientific evidence, to show that that program has led to decreases in fear of cancer recurrence, decreases in stress, and increases in wellbeing and sleep quality. There's also a whole range of studies that have looked at mindfulness-based interventions, but I've chosen one or two here, or one that I've got here for mindfulness-based stress reduction, which also led to significant decreases in fear of cancer recurrence, fatigue and stress. So I think we're on my final slide. The important part of all of this, in a short talk, I really can't cover all of the possible sources of distress or the ways to treat those, but I hope that you can be encouraged to develop your own coping strategies, to be aware of what works for you, because just like the impact of a cancer diagnosis and treatment and so on will vary from person to person, the best coping strategies vary from person to person too. When you need additional support, it is available, it is out there. So I've put a few examples of ways to access it on the slide. A fairly straightforward ways to talk with your GP, and that would apply for people who are undergoing cancer treatment or a post-cancer treatment, as well as carers for cancer survivors if you need to access support. You might want to see someone specifically with knowledge in cancer, and if that's the case, often a referral from someone in your cancer care team is useful, because they'll be used to working with people and will know some of those people that have that experience. Support groups can also be really helpful, and those don't necessarily have to be face-to-face. There are a lot of online options as well. So if you are in an area where you don't have many people with a similar experience, you can still connect with other people. And finally, if you don't have personal recommendations from your health professionals or treating team about where to access a psychologist and you'd like to see one, the APS does have a website that helps you to find a psychologist in your area with particular skills and expertise. That's it from me, but I look forward to answering questions later on.